Thank you very much. Thanks, Graham, for organising this fantastic meeting. It's very heartening. I think there's a theme emerging out of this, which is it's all about the people. It's all about the many and not the few. And it's all about the common journey that I think all of us in this room have made in our respective and different ways about really asking the question, well, what difference did we make? What did the continuity do? What did we do? And I think the other question we should ask ourselves is, how much more could we achieve? What are we not doing? And so that's kind of what I want to reflect on a little bit today. So I think we've been looking in East London to build learning health systems with our patients so that every patient contact is an opportunity for learning. And we've got a group of about 30 people who are funded by CCGs to support quality improvement. We're now covering 7 CCGs, a population of about 2 million, which is about the size of Glasgow, Edinburgh, and Aberdeen combined. 250 general practices, 1,000 GPs. And, you know, we're a very diverse community. 50% of our population are not originally from England, and they are very diverse, and they are very disadvantaged in various ways. And this is the East London diabetes belt, which is a bit like the southern states of America. 1 in 10 people have diabetes in those red areas. You can see the River Thames there with the kind of leafy loft side apartments, and then Victoria Park on the other side with the sort of main roads running through the middle and all the council estates. So that's where we are. So I want to talk about that journey. How many of the GPs in this room are still writing by hand in their notes? Anybody? 1, 2? And how many are writing on a computer? So we have a different world from where we started with our A4 records back in Glencorrog. When I arrived there, they were in the middle of a measles epidemic. I hope that wouldn't happen these days. So our journey is that we are now high-performing CCGs despite exceptional challenges. We're a decade ahead of similarly disadvantaged areas. And we have worked with a very diverse group of organizations, practices, CCGs, STPs, public health and research. Those kind of people on that road could be any one of the people in this room. And I think what we'd all agree is that there's no pie in the sky, to quote Joe Hill at the end of this. Perhaps we can do better than we are at the moment. Oops, wrong way. So the learning health systems are built on trust, fundamentally, trust with our patients, trust with our organizations, and it's a reciprocal trust. It's about giving back. What can I give back to general practice rather than what can I just take out? It has a clinical focus, and the business intelligence and research are byproducts of that relationship. And it has a digital infrastructure now, which is an essential component. You can't ignore that. And for people who want to kind of read a very good report, the VACTA report is a very good report on technology and development. But this fundamentally comes back to the people. Here are practice teams. They're in an office just above Spitalfields, above Brick Lane, and there are the practice teams, healthcare assistants, practice managers, nurses, GPs. This guy's a consultant diabetologist. On the table, you can see one of our guidelines, and they're looking at a RAG chart to say, well, how can we do better for blood pressure control or for HbA1c? And you can also see on the table the statutory high-calorie orange juice, sausage rolls, and crisps, which are essential to any good MDT. Our group is academically connected, and we have amongst the most successful quality improvement in the UK in some selected measures that you can do something about. So here's the story in City and Hackney. They started off with the quality and outcomes framework. Right down at the bottom for diabetes, cholesterol, there are 209 or 211 CCGs in England. They were 181st, right down the bottom. And then you can see their sort of progression. They're now kind of top of the heap, and in all the 26 clinical measures, they rank, first or second in England in 11 of them. And the other CCGs in East London, Newham, Barking, Dagenham, Redbridge, Hamlets, Waltham Forest, Havering, are all doing kind of quite well as well. So here's our per capita spend, adjusted spend is PUs, it's a population adjusted. So we've got an order of magnitude above the average in England of per capita spent on statins, and that applies also to City and Newham. Here's high-intensity statins for CVD, which is what you should be giving for people who've had a heart attack or stroke. And you can see we're doing very well. But that CCG at the top there is Bradford, where they made a decision to switch everybody onto Atorva 40 or 80, and they just bang. And so we've got some more room to improve over there, but everybody else is rather far behind. So here's coronary heart disease blood pressure in QOF. And the kind of rich folks, this is index of multiple deprivation, and you can see the rich folks, Guildford, Surrey Downs down this end at the left, and sort of disadvantaged areas like ours. And we're above the average by about 5 percentage points and above similarly disadvantaged areas by about 10 points. Each percentage point is about a year in improvement terms, so we're 10 years ahead. Same with cholesterol. And here's an example of those trajectories over time. The green, the red group are City and Hackney, the green is Tower Hamlets, and the blue is... So there's an 8% gap. We're doing as well as Kaiser Permanente in Southern California, but we haven't excluded any populations for selected measures. I'm sure they do more hip replacements, more appendectomies, but on some things we're doing, particularly childhood immunizations. And even for things that are not QOF measures, we're doing well for reducing unnecessary treatments like long-acting analog insulins in people on type 2 diabetes, reducing NSAIDs, and improving our antibiotic profiles. This is just an example of organizational change at scale. This is pulse checks we're doing in people over 65 to detect AF. In Waltham Forest, they don't have a program, so there's wide variation. Some people are already doing it. Many people aren't, and they average about 20% in Newham. They've had a program going for 3 years. Everybody is up there. The point is that nobody left behind. The culture has changed. If you take off the financial incentive, it'll drop a bit, but it doesn't go back down there. So you can change culture in quite a big way. Here we're looking at EGFR, surveillance and populations. If we'd identified that person there, we could have stopped them crashing out, and we've got sort of systems whereby we can monitor people with poor renal function and get them beforehand. And here's looking at the public health issues. We're beginning to get practice data out into localities so that you can look at this data. This is smoking data, but it could be diabetes data, or it could be whatever you choose. So it's a system, it's not a plug-in. It's all about how you get your stakeholder consensus in the first place. And that can be quite difficult. You then need to make your key performance indicators actionable with IT support, on-screen prompts, script switches, trigger tools, patient call, recall lists, and then finally motivating people by showing them their performance. How are you doing now? 70%. How far do you have to go to get to target? 80%. You've got another 15 patients to call in to improve your COPD care or your blood pressure or whatever. Here's an example of the sort of the guidelines that we produce. Here is an example of reducing self-monitoring for blood glucose in type 2 diabetes. If you're not on insulin, you don't need to do this for most people. It's the second most expensive part of diabetic care after insulin, and more than half our patients were getting this unnecessary finger pricking back in 2008. And we said, no, you don't need to do this. Newham said they didn't want to take part, so you can be the control group, that's fine. And we reduced it to less than 10%, so huge impact. So you can make this action by having single systems for IT. It needs to be locally engineered and responsive, and it needs to be GP provider facing fundamentally, and then secondarily CCG and public health facing. But we also need to have facilitators, people who go out into the practice and say, this is the template you should all be using for your data. Here is the money shot. Here's the sort of things that you should be doing so that there's a human interaction saying, this is what we would like you to do. And that's very powerful. Our facilitators are usually women locally recruited. They were often receptionists and staff or administrative staff who've gone out into the practice, and they know the practices very well. So this is a kind of example of some of the tools that we use. This is a tool for AF. It'll show you in your practice identifiably people are on aspirin monotherapy. And it's giving you a list down here of the individuals. You can choose with these radio buttons, people on aspirin monotherapy. You click on any of those buttons, and it gives you a page for your patient that will show you this patient. They're 80. They are on aspirin only, but they've also got dementia, palliative care, and so on. So I'm not going to rush in and say you need to be on anticoagulant. In fact, I might review whether or not you need to be on your aspirin. So other dashboards are like this. So we chose wisely about what we did, things that we could do something about. We have smart multi-morbid templates so that the template knows whether you've got AF and COPD and diabetes. You don't have to go from one template to another. So it was giving back GPs working smarter, more efficiently, and often creating a financial incentive that was on and above what they were already getting from QOF. So that was a learning health system, and we pushed ourselves up into top in London and the UK. But we've still got this situation. We've got EMIS, or it could be TPP, or it could be whatever system. Cerner is whatever your hospital system is, and then local services, and NHS Digital saying you can't come in here. So that's going nowhere. It's not fit for clinical purpose. That we need to build that trust. The NHS is a trusted entity, local data ownership, federated structures. People are not going to put all their data right up here. They want to say it's our data. Born in Bradford has been very successful because it's got that local ownership, and the same, we've got programs going in East London like this. So tools for the job, no good having Windows XP, WannaCry problems, smarter working for clinicians, high quality data, single entry, not this repeated errors, and accessible for patients and professionals. So in East London, we've got a viewing where we have 100,000 views every month of each other's records in the hospital and GP records. It's the norm. But it's a view. It's like a PDF. It's a selected view. It shows you can see my problem list, the medication, and so on and so forth. So I don't get rung up constantly from the hospital saying, I've just admitted your patient. Could you tell me what they're taking, please? So you won't get this. So it covers all providers in East London: mental health, hospice, hospitals, ambulance, and out of hours. But that's not good enough. That isn't having the data. We need the actual information in order to use it for identifiable patient care. And so we're building a program around discovery to integrate all the GP and hospital records so that it will provide real-time clinical care. I would also point out that there are commercial versions of this coming around. So Cerner, one of America's biggest billion-dollar corporations, already has hospital systems in the UK and is putting out a system called Cerner Health e-Intent, which is being used in north central London, and to do the same thing. So, it's all about it's the new kind of enclosure, really, closing the data space, I think. And Alison, I'm sure you'll be on to this, I hope very soon, to say what's going on here, because it's very important. So this is the kind of thing that will create the discovery, a data service, an information service that comes out of that. We need to get all the data into one place. At the moment, we're funded by a charity, by David Staples, who used to run EMIS, but has taken his fortune and put it into this. The kind of thing it will give us is near real-time reporting. We can relate process to outcomes, so I can relate not only who is on an anticoagulant, but how many strokes my CCG has had within a year, for example. No duplicate testing, predictive scores, research, patient connecting in apps, and connection to social services and 111. So we've created a frailty flag from our GP records. That now flags up when you ring the 111 service about your mum saying she's not well. It will say, this is a frail person, so that the call handler knows to put that call straight through to a clinician rather than going through some complex algorithm. So it's just one example of this kind of joined up thing. So we're looking at wider picture, how we might relate to Health Data Research UK on this, One London integrated records, and in particular, health data science, patient and virtual healthcare applications. But the future's already here. It's not equally distributed. And are you really satisfied with just good enough, 60 or 70 or 80%? Why don't you go for excellence, like 90% or more? So we have fewer than 50% of our patients with high-risk CVD who have their blood pressure controlled on high-intensity statins, that rule of halves. Hepatitis C is a curable disease. We haven't even begun. The same with latent TB. Levels of preventable bleeding and hypoglycemia are frankly a disgrace. They are the commonest causes of admission to hospital for adverse drug reactions. And other immutable adverse drug effects are epidemic. So the greatest impact of health services is to deliver existing effective services more completely, safely and equitably. And I think that that's really where we should be putting our energies. So a digitally enabled learning health system is part of the solution. But at the end of the day, as we've heard constantly, it's a system built by people, not a plug-in. Thanks very much.